Hello, my name is Ravi. I'm from My Cancer Haven, and today in our cancer expert series, we're going to be talking to one of the renowned myeloma experts from one of the most prestigious cancer institutes in the country, Memorial Sloan Kettering Cancer Center, and we have Dr. Hamza Hashmi here, who is assistant professor at Weill Cornell Medical College and attending physician on their myeloma service. And he's going to talk to us about a contemporary topic today as to how we choose between CAR Ts and bispecifics as they both move into earlier lines of relapse. Welcome, Hamza.
Thank you so much, Ravi, for having me come in and talk about a very debated and discussed topic in myeloma field right now of CAR T versus bispecific to first relapse.
Well, let's get started. So let's just first talk about the data that came out at the American Society Hematology meeting in December that has caused a lot of excitement and got recently approval as well through the FDA. So the Majestic 3 study, could you, for our audience, tell us what this study set out to do?
Yes, Ravi. So Majestic 3 was a phase 3 randomized control trial that has essentially revolutionized the treatment outcomes for a myeloma patient at the time of their initial or first relapse, and has shown some profound efficacy that has been unprecedented up until now. So it was a randomized phase 3 control trial that looked at patients with relapsed myeloma who have had at least 1 to 3 prior treatments given to them. And these patients were randomized to either receive combination of daratumumab with teclistamab, bispecific antibody, or receive standard of care chemotherapy combinations like daratumumab, pomalidomide, dexamethasone, or daratumumab, bortezomib, dexamethasone. The trial in total had about 600 patients that were randomized 1-to-1 to either receive the experimental arm of tec and dara or the control arm, as we call it, of darapom dex or bortezomib dex. It's interesting to see how teclistamab was given in this trial in combination with daratumumab. It was given weekly for the first couple of months. After that, it was given every 2 weeks for 4 months. And eventually, after 6 months of treatment, teclistamab-dara combination was given every month until the patients progressed or had intolerable toxicities. Darapom-dex, darabortezomib-dex were given in the same way we have historically given this therapy. Primary endpoint for this trial was progression-free survival, and important secondary endpoints were response rates, minimal residual disease negativity, overall survival, and total symptom score.
So
Next slide, please.
I was saying this was an early de-escalation of teclistamab, not like the packet insert for the relapse refractory disease.
Absolutely. Teclistamab, when it first got approved as monotherapy for relapse myeloma after 4 prior lines, was given weekly until disease progression. There was some data showing that after 6 months or so, you can perhaps give it less frequently, maybe every 2 or every 4 weeks. This is what we do in our practice. But this was the very first trial that actually gave early de-escalation within 2 months' time to every 2 weeks administration, and within 6 months' time to every 4 weeks administration. So that was also a major important highlight of this trial of giving less frequent teclistamab to see what effects it has on efficacy and safety.
Though they did use a slightly higher dose of the teclistamab when they went to less frequent administration.
Yes. So the weekly dosing for teclistamab as a monotherapy for relapse myeloma is 1.5 milligrams per kilos. But when patients received it every 2 weeks, or for that matter, every 4 weeks beyond 6 months of therapy, it was given at the 3 milligram per kilos dose monthly.
So could you tell us what's the rationale? Why go less frequently? Is it just convenience, or are there other things that get sorted out by less frequent administration?
Yes, Ravi, that's a very good question. So we have learned from our real world practice and evidence that giving teclistamab less frequently not only preserves the efficacy, especially for patients who already seen some response, that it prolongs the response even when given less frequently, but more importantly, it has a better effect on the immune profile. It leads to a lower incidence of hypogammaglobulinemia and also leads to an improvement in the risk of infections as these patients continue their therapy. So all of these lessons that we learned from our real world practice were translated in this particular trial.
So what was the demographic of the patient population accrued?
Yeah. So you can see here that a median age for this patient population was around 65. Only 10% of the patients are above the age 75, and they were all fit and healthy based on their performance status. Only 5% of the patients were African American, and in fact, when the trial was accruing patients, I was an investigator on the trial. There was a mandate from the sponsor to actually enroll more African American individuals so that we can ask the FDA for approval of this combination therapy. And hence we saw some accrual in US of African American individuals as well. About 10% of these patients had advanced stage ISS disease, about 10% had extramedullary myeloma, and I would say about 10% of them had high bone marrow disease burden of 60% or more plasma cells. Having said that, when you look at high-risk cytogenetics, including deletion 17p, chromosomal 414 translocation, 1416 translocation, which we define as a high risk by IMWG criteria, 1 in 3 patients actually had high-risk cytogenetics. Vast majority have had prior bone marrow transplant done. A vast majority were lenalidomide refractory as well, and on median, patients had about 2 prior lines of therapy. A very important point to highlight here, Ravi, is that on this trial, patients could have had exposure to daratumumab, which is only 5% of all patients, but they could not be refractory to the daratumumab or CD38-based antibody. That's an important distinction as we talk about how to use this therapy at first relapse and how it compares in regards to the CAR T-cell therapy that's also available at first relapse.
So, what were the top line results that caused all the excitement?
Yes, Ravi. So at 3 years follow-up, we learned that the combination of teclistamab and daratumumab still has not reached its median progression-free survival. Compared to Daratec combination, the median progression-free survival with Darapalm-dex or Darapotezumab-dex is around 18 months. That's very reflective of what we have seen in our real-world practice pattern as well, that at first relapse, if you use Darapalm-dex or Bortezumab-dex, it usually gets to 18 to 24 months. So a very comparable comparator arm. Interestingly, when you look at a 3-year follow-up, you see that the estimated progression-free survival is 85%. And when you look at this curve, you will see that beyond 6 to 12 months, you actually are not seeing any relapses happen. So very deep, very durable remissions that we actually saw that led to a hazard ratio of 0.17 essentially means that 83% of the patients were actually progression-free and alive 3 years after starting their treatment.
That's remarkable. And what about the overall survival?
Yes, even the progression-free survival benefit of the deep and durable remission, in fact, also translated in a longer life or overall survival benefit for these patients, where a 3-year follow-up, 85% of the patients were alive compared to 65% in the control arm. One interesting thing that we learned on this trial as we were accruing patients as well, that early on, within the first 6 months interval, there was actually an overlap of the two curves, where you can see that the patients with teclistamab-dara combination had a higher incidence of early mortalities that was related to infections that are related to hypogammaglobulinemia in the era of a pandemic. And as we learned from our lessons in the real world with teclistamab monotherapy, after February of 2023, we mandated IVIG use. Also, we were learning a bit more about the pandemic. We had vaccinated a lot of our patients. And as time went on, beyond 6 months, we started seeing a significant decline in the risk of hypogamma and infections-related mortality. And hence, that's why we start seeing a difference, in fact, emerge in the overall survival as well for these patients who receive Tec and Dara combination.
And was this limited to certain subgroups, or was it pretty broad-based, the benefit?
Yes, Ravi. So looking at this slide, you can see that we had multiple subgroup analysis performed. And you can see that a benefit of Tec and Dara for the progression-free and overall survival was seen essentially in all subgroups. No matter how you slice the data, you will see that Tec Dara combination is outperforming the salvage chemotherapy. In fact, I would like to highlight here the high-risk cytogenetics, which was 1/3 of all these patients, where the benefit that our patients got for high-risk myeloma with Tec Dara combination was very similar to the benefit they were getting if they had standard risk myeloma, which is something that we have not seen consistently previously, that with very effective therapies, we still see that a high-risk myeloma based on cytogenetics does not do as well. But in this trial, the hazard ratio is essentially similar. There were certain subgroups, I would say, where the benefit was seen with the Tec Dara combination, but perhaps was not as good as it would have been otherwise. For instance, patients who were Black, patients who had ISS stage 3 or bone marrow plasma cytosis. I think it has a lot to do with the number of patients that were in each subgroup. and hence the power may not be adequate to actually have a subgroup analysis that clearly establishes the benefit in some of the high-risk groups as well. But to summarize, I would say that high-risk cytogenetics clearly benefited as much as standard risk did with this combination.
And what can you tell us about the dynamics of the response and the depth of response?
Yeah, so responses were very deep, very durable, and very early. If you look at the slide, you can see that 90% of the patients actually had a response. And a vast majority of these responses, nearly 80% and beyond, were complete responses or better. Very few patients actually had a VGPR or PR. Time to first response was as early as 1 cycle, 1 month of therapy, and time to best response, a complete remission, was in fact 6 months or 6 cycles of therapy. And those who did have a response, which is again 90% of these patients, their duration of response at 3-year follow-up was close to 90% of them are still responding. So very early, very deep, and very durable responses seen on this particular trial.
Pretty remarkable. And if we go on a deeper analysis with MRD, which is becoming increasingly a talked about endpoint.
Yes, Ravi, this is absolutely correct that MRD negativity has emerged as a strong regulatory endpoint to get early drug approval through FDA for all the novel therapies that we have on the horizon. And I would say, before I dive into the MRD results, that the way MRD assessment is conducted nowadays is by and large by next generation sequencing, where we have a bone marrow sample at the time of diagnosis of relapse, and then we have another bone marrow sample looked for the MRD at the time the patients have achieved a deep remission. In this particular trial, all patients had assessment done through the next generation sequencing method. They had assessment at 10 to the power 5 and 10 to the power 6 strengths, looking at 1 in 100,000 and 1 in a million cells. And there were patients who, at the time of their MRD assessment, which was done at 6 months, 12 months, 18 and 24 months, who may not have had a baseline sample, who may not have achieved a complete remission, and who may not have a calibration process being performed on the follow-up sample. So when we look at all of those patients, about 55% of them were MRD negative, because any patients who did not have a baseline sample, who did not achieve a CR at the time of assessment, or who could not have a calibration performed, were deemed as MRD positive. However, when we did a final analysis, that only looking at patients who had a baseline sample available, only looking at patients who could have a calibration performed, and finally looking at patients who achieved a complete remission, we saw that 90% of the patients were MRD negative at the time of their complete remission, which tells us how deep a response can be achieved with this combination therapy.
And obviously, the question becomes, you're getting deeper responses, better responses. What about the toxicity?
Yeah, so here you can see that hematologic toxicities were seen, primarily neutropenia. Every 3 in 4 patients would have some degree of neutropenia. We typically see it, Ravi, in the first cycle or so, in the step-up dosing of teclistamab and with the additive effect of daratumumab, that you see neutropenia. We don't see as severe or prolonged lymphopenia, anemia, or thrombocytopenia with this therapy, especially once myeloma comes under control. CRS was seen in about 60% of all patients. CRS is essentially a fever with allele cytokines. And on this trial, no prophylactic tocilizumab was required. And with that, 60% experienced CRS, and vast majority were grade 1 CRS, which is fever alone. And only about 15% had grade 2 CRS. There's only 1 or 2 few cases of ICANS that was seen with this combination. Having said that, there was a risk and concern for hypogamma that led to infections, and infection that led to early mortalities. I would say the risk of hypogamma is actually as high as close to 90%, and risk of infection, severe infection, was as high as 50% with this combination therapy. In total, there were about 7% of the patients who died related to treatment on the experimental arm with the tech and dara combination, and a similar percentage that actually died in the control arm as well from the treatment.
So what about infections in a greater detail?
Yes, Ravi, as we discussed, that the risk of hypogamma is significant with the tech and dara combination. 90% of the patients are experiencing some degree of hypogamma, and nearly 95% of the patient had an infection. Amongst the patients who had infection, nearly 50% of them was severe infection that required them to be in a hospital, receive IV antibiotics. And most of these infections, Ravi, they were related to the respiratory tract, either an upper respiratory tract infection or a lower respiratory tract infection. And amongst these infections, the most severe ones were actually COVID and non-COVID related pneumonias that we saw on the trial. And these infections were a major cause of mortality within the first 6 months, where the risk of infection was actually as high as 35%. As more time was spent on therapy, as patients started doing getting better control of their myeloma, only receive Tech and Dara combination once a month beyond 6 months, with the mandates of IVIG, with the better control of the COVID pandemic, we actually saw a decline in the risk of hypogamma and infection between 6 and 12 months. And beyond 12 months of treatment, the risk of infection is only around 5 to 10% for these patients. But it does highlight the need to actually boost the immune system by the use of monthly IVIG. In our own practice, we actually start patients on IVIG as early at the start of second cycle. We try to avoid it with the step-up dosing because it's hard to distinguish the fever that you see from a reaction to IVIG from a fever that you see from CRS from teclistamab. But as per the guidelines that have come forward and what we learned from our trials, IVIG is mandatory for all patients in Tec-Dara combination as early as second cycle, regardless of your IgG levels.
So let's switch gears and talk about a competing technology and then come back at the end and see how you think through these two options. So the cell-to-cell data, the CARTITUDE-4 study, put that in perspective.
Yeah, so Ravi, CARTITUDE-4 was again a phase 3 randomized control trial that looked at patients with relapsed refractory myeloma who have had 1 to 3 prior lines of therapy and either gave them a single one-time infusion of a CAR-T product known as cilta-cel, or they received standard of care chemotherapy in the form of dara-POMDEX or bortezomib-POMDEX. In this trial, again, there were close to 400 patients. They were randomized 1-to-1 to receive one of the two therapies. The patients who were on standard of care arm, chemotherapy alone arm, they got chemotherapy started right away. Having said that, the patients who were experimental arm who received CAR-T, they had to hold all treatment, undergo leukapheresis for CAR-T, then start bridging therapy, and once the CAR-Ts become available, receive the CAR-T cell infusion. And what they could receive for bridging therapy was either dara-POMDEX or bortezomib-POMDEX to maintain some degree of comparison between the experimental and the control arm on this particular trial. Again, the primary endpoint of this trial, just like the MajesTEC-3 trial, was progression-free survival, and the secondary endpoints were response rates, MRD negativity, overall survival, and patient-reported outcomes. If you look at the patient population for the two trials, you can see that the median age was around 60. Advanced stage ISS disease was again seen in about 5% of all patients. High disease burden was 20%. About 5% of the patients had EMD. An important distinction here is high-risk cytogenetics alone, deletion 17p, 414, 1460. Very comparable rates of about 35% in this trial as well, as compared to the MajesTEC-3. Having said that, the major distinction that we saw in this trial and the MajesTEC-3 trial, comparing again CAR-T at first relapse versus Tec-Dara combo at first relapse, was that 25% of the patients on this trial were not only Dara exposed, but also Dara refractory. Almost everyone on this trial was lenalidomide refractory. So daratumumab refractoriness, Ravi, has emerged as one of the biological markers of more aggressive disease. So if I draw a fair comparison, I would say that on this particular trial, the patients are a bit more heavily pre-treated and a bit more refractory than what we had on the MajesTEC-3 trial.
And what did this trial show in terms of results?
Yeah, so it actually showed, again, very deep and very durable responses, not only in patients who, in fact, had standard risk myeloma, but in fact, those who had functionally high-risk disease. And functionally high-risk disease is actually a disease of relapsed myeloma, where patients who relapse within 18 months of frontline therapy or within 12 months of a transplant, even when they have had normal cytogenetics. And we do take that as a marker of more aggressive disease biology, a worse resistance pattern to all therapies, and inferior outcomes as well. And what we learned on this trial is that the patients, whether they have standard risk myeloma or they have functionally high-risk myeloma, they actually reap very similar benefits, where nearly 90% of them would have a response, close to 70 to 80% would have a complete response, and in 12 months, nearly 80% of these patients were progression-free and alive.
And this, you said, also was for the standard risk?
Yes. So when we look at these deep responses, where nearly 2/3 of the patients are MRD negative after one-time infusion of cilta-cel, that also translates into a durable remission that you actually saw the 3-year follow-up in last year. And what we learned in that is that patients who receive CAR T cell infusion at 3-year follow-up, their estimated progression-free survival is actually somewhere around 80%, very comparable to what we saw with Tecendera. When we also look at patients who had standardized myeloma and in addition had a 1Q abnormality, we still see a significant benefit in the progression-free survival, but maybe a little bit lower than what we see with standardized myeloma without the 1Q abnormality. It does lead to an overall survival benefit on nearly 80-85%, which is very comparable again to Tecendera combination. And in fact, we have drawn comparison of this 3-year progression-free survival with what in CARTITUDE-4, where patients got CAR T at first relapse and compared it to patients who got CAR T after 6 prior lines of therapy, and could clearly see that the patients who get CAR T early have a more deeper and durable remission as compared to patients who get CAR T at a late line.
And I guess even in this population, the tolerability of this modality is reasonably good.
I would say so, Ravi. If you look at this particular slide, you can see that the CRS, which again in a vast majority of our patients is just a fever, happen in about 75% of the patients. Typically happens within first week of infusion. Usually it's a grade 1. It's very easily manageable with tocilizumab and dexamethasone-based therapies. ICANS rate are actually really low. I would say less than 2% in these patients. And when you start looking at some of the late onset non-ICANS neurological toxicities, we classify them as a cranial nerve paralysis or Parkinsonian features. There were very few cases of those. In fact, on this particular trial, they did not report any cases of Parkinsonism. You do see some degree of hypogammaglobulinemia. It's not as severe and profound and prolonged. The risk of infection, all grades of infection, is somewhere around 50%. A grade 3 or higher infection, which push patients in the hospital, require antibiotics, is actually around 25%, which is essentially half of what you would see with a Tecendera combination of around 50%. So better profile on the immune profile with not as severe hypogamma, not as severe infection, not as frequent infections, and really a decline in the risk of hypogamma infection beyond 6 months of CAR T. So overall, well-tolerated one-time treatment. Having said that, Ravi, there is a lot of concerns that have emerged over the last few years regarding the risk of Parkinsonism in patients who receive cilta-cel. It has been attributed to the hyperexpansion of T cells that actually are not only cause cranial nerve palsy, but also in fact lead to some permanent deficits in the neurological symptoms in the form of Parkinsonian-like features, where patients may have difficulty with their cognition, they may have tremors, resting gait, change of personality. We have gotten better in how to identify these symptoms, how to identify the triggers of these symptoms with blood monitoring, but we still are struggling at completely preventing it, and for that matter, treating it if it happens. So that continues to be a concern for our patients as you go through this particular treatment.
So obviously with CAR Ts, there's been a lot of excitement recently related to an earlier study, the CARTITUDE-1 study, where more heavily pretreated patients were given the drug, and we see at roughly 5 years, 1/3 of people progression-free. What do you think this holds for CAR T in the future?
Yeah, so Ravi, this was the long-term follow-up on CARTITUDE-1 study, where patients with relapse myeloma who were triple-class refractory, had 6 prior lines of therapy, high disease burden, extramedullary disease, high cytogenetics, who if you give them standard of care chemotherapy combination, may not have survived beyond 6 to 9 months, receive a single one-time infusion of a CAR T. And essentially 98% of them had a response, 80% complete response. And at 5-year follow-up, we learned 1 in 3 is progression-free and alive. And even half of these patients are actually alive, who to begin with, in fact, had less than 6 months to live. So this was truly hailed as a major milestone in myeloma, for myeloma therapies and myeloma patients, where New York Times rightfully suggested that CAR T may be the potential cure for an incurable cancer. We know that if a therapy works this good, late in line for multiple myeloma, moving it all the way in the frontline settings at the first relapse or at the time of diagnosis can potentially cure myeloma, where patients may not need any treatment given after a single one-time infusion for this foreseeable future. So I think it was a major milestone that we achieved with the myeloma therapies.
No, certainly, I think that the talk of the cure has certainly come into the lexicon of myeloma post the CARTITUDE-1 study presentation, and I think that people still feel that longer-term follow-up is warranted before we have, declared that everybody on that curve that hasn't yet progressed is cured. But certainly, exciting data. So, how do you put it all together? So, in your own practice, if a patient comes in having relapsed after frontline therapy, what do you do these days?
Yeah, Ravi. So if I have a patient who comes into my clinic at a time of their first relapse, I think my preferred option for many of my patients continue to be a single one-time infusion of CAR-T. And I have some strong rationale and some biological explanation and data-driven approach towards this. We know, comparing Majestic 3 and CARTITUDE-4 study analysis, again, it's not a pure randomized control trial or a very clean comparative analysis. We know that outcomes with efficacy, with the depth of response and durability of response are very similar. But we also know that teclistamab dara combination is an ongoing treatment that needs to be continued until disease progression, where CAR-T, on the other hand, is a single one and done treatment. More importantly, we know that patients who go through CAR-T and let's say relapse few years down the lane still have the option of availing the combination therapy of teclistamab and daratumumab and still get benefit out of it. Based on our real-world analysis, where teclistamab has salvaged patients after CAR-T relapse. Having said that, patients who receive teclistamab and daratumumab-based combination, oftentimes when they relapse, have either a downregulation or complete loss of the target protein of BCMA on their surface, where CAR-T may no longer be an effective option for those patients. Moreover, with the clonic stimulation of these T cells, we do worry about collecting and producing and manufacturing healthy T cells. We also know that with subsequent relapses, the tumor microenvironment may become more inhibitory and may not be as conducive to the CAR-T efficacy. So just purely from an efficacy standpoint, CAR-T seems to be a better option given first. And if there's a future relapse, the combination of teclistamab and daratumumab is very amenable. It also actually is very true when it comes to the side effect profile, that teclistamab and dara combination has a very high incidence and rates of hypogamma, infections, and impact on quality of life. On the other hand, the risk of hypogamma and infection and lifelong need for IVIG is not as significant, and it does impact the patient's quality of life, the freedom from cancer treatment, from clinic visits, from being in infusion all the time. So I think these are some important distinguishing features of tec-dara combination versus CAR-T that usually have me choose cilta-cel or Carvykti as a first option for patients at the time of their initial relapse. Having said that, I have patients who come into my office who I believe are in dire need of a treatment. They need myeloma therapy done next week, not in 2 months' time, which is the amount of time it takes to collect T cells, freeze them, manufacture them, purify them, grow them, get them back into the patient's body. So the patients who are in urgent need of treatment change, I do actually start them on tec-dara combination to get early and deep responses for those patients. Also, there are patients who are elderly, who are frail, who have advanced stage organ impairment with perhaps unstable kidney function, symptomatic heart failure, COPD with oxygen dependent. Those patients may not be the ideal candidates for a treatment like CAR-T, and hence starting them on combination of teclistamab with addition of daratumumab later may be a more viable option, because you can still give teclistamab safely to these patients with some prophylactic measures. And the third group of patients that I usually consider tec-dara combination for would be someone who doesn't have a caregiver, or is in fact a caregiver for another person, another family member that cannot take the time away from family, from home, and stay in a big city, a big academic center where they have to be stationed for at least a full month, and may not have the ability to make to such a commitment. For those patients, I think outpatient step-up dosing with teclistamab is very feasible, and then keeping them where they live, close to your family, that Tera combination becomes a very desirable option.
So if you do give a bispecific, do you intend to give it till progression as these trials have done, or do you think giving it for a shorter period of a year, 2 years, uh, is going to be something that is worth doing for some patients?
Yeah, Ravi, that's a very, very good point that you're bringing up. So, in my own uh, experience, in my own practice, the way I envision to actually implement this, having been a part of the trial and enroll patients, you see very few relapses happen beyond 12 months. In fact, beyond 6 months, you don't see any of the patients relapse. At 12-month mark, a vast majority of CR patients, 90% in MRD negative. So the way I would choose to give Tectera combination is that if a patient has already achieved CR and if they're willing to perform a bone marrow biopsy and imaging and they're MRD negative, I would have not have any hesitation to stop all treatment for an MRD negative CR at 12-month mark. Now, in fact, there are trials, Ravi, right now that are investigating this with teclistamab, where patients get teclistamab for 12-month mark, and if they are a VGPR, they either undergo observation or teclistamab every 3 months or teclistamab every month. So trials are already investigating it. I'm sure they will read out pretty soon, and we'll have a better idea. But I think the efficacy is so profound that we need to balance out the safety and the quality of life by doing time-limited treatment for many of our patients.
What if you stop and the patient relapses years later? Do you think you could do a CAR T then?
It remains an option, Ravi, for patients as long as, again, they have had the target intact. Because 40% of the patients, they when they relapse, while they're on therapy or even after when they have experienced a treatment-free interval, they have dynregulation or complete loss of BCMA. And if they don't have BCMA expressed at all, I don't think there is any role of CAR T at that time. But having said that, we have so many other options that are on the horizon, whether it's a cell mod, it's a GPRC5D CAR T, or a bispecific antibody. There are abundant options available for those patients. But if someone has had Tectara combination, has been treatment free for several months and years, and still have the BCMA target in place, I would give consideration to CAR T cell therapy for those patients.
Do you think in the future we will be testing for these various antigens and then deciding based on what the particular patient's tumor shows?
I think it's already being done at some major medical centers. Whether that's actually translates into our community practice as well, it needs to be seen. But major academic centers are already looking for not just a structural loss of BCMA, but in fact functional mutations as well. Because you can in fact develop functional mutation in the BCMA where even the CAR T doesn't bind the pocket of the BCMA. So I do think that our decision to re-challenge someone with a BCMA CAR T, once they have a relapsed on BCMA bispecific, will largely be dependent upon what's the status of the BCMA antigen. I think without that, it's more like a shot in the dark. And we want to offer the best therapies for our patients, and hence it has to be in one form or the other, whether you're looking for the expression of BCMA or the genetic mutations of BCMA should be taken into consideration.
Well, I really want to thank you for educating our audience about this complex topic and obviously exciting times and a lot more happening. And as we learn more, would love to have you come back and tell us about how practice evolves going forth.
Thank you for having me, Ravi.
I would hope to see you again soon. Take care.